All right, everybody. Thank you so much for joining us here today, Saturday, August 21st, the last day of the 7th UMD Symposium on Environmental Justice and Health Disparities. This afternoon we have, or this morning and this afternoon, we have a few different sessions that are related to the Environmental Public Health Tracking Program administered via the Maryland Department of Health. And today we have Dr. Cliff Mitchell, the director of the Environmental Health Bureau, here with us today to show demonstrate the new EPHT tracking tool, in addition to an overview of the program. Dr. Mitchell's responsibilities include environmental public health tracking, monitoring hazardous algal blooms, coordination of environmental health activities with other state agencies, and the direction of the department's preventive medicine residency program. Thank you so much for being with us here today, Dr. Mitchell, and feel free to take it away.
Thank you, Joe. Let me just confirm that you can hear me okay.
Can hear you great.
Okay, great. It's lovely to be here. It's obviously been a very stimulating several days, and I really want to thank Dr. Wilson, the other organizers of the Symposium on Environmental Justice and Health Disparities, for the opportunity to chat with you this morning and this afternoon about what the Department of Health, some of what the Department of Health is doing to address issues related to environmental justice. And so as we begin, what I'd like to do, many of you may be familiar with the Environmental Public Health Tracking Project nationally. I'm going to give a little bit of an overview of that, and then talk about how in Maryland we are rethinking our environmental public health tracking portal in light of the many conversations that have been taking place around health equity, environmental justice, and really using data and the work that happens in the public health department to achieve change, significant change. And I want to start off by acknowledging several people who are in the room who are participating in this project, in addition to Joe and Dr. Wilson, who are assisting us in outreach and education activities, but also Shubha Chandar, who is the Deputy Director of the Environmental Health Bureau, and Carolina Rodriguez are two of the people who have been instrumental in the development of the new portal, along with a team from the Towson Center for Geographic Information Studies at Towson University. So let me just give you a little bit of a history. And I would just remind you, for those of you who are not familiar with environmental public health tracking, that in about 2001 and 2000, the Pew Commission, chaired by Dr. Thomas Burke, who was the former environmental commissioner for the state of New Jersey, and who was subsequently at the Johns Hopkins Bloomberg School of Public Health. That commission looked across the many kinds of surveillance activities that were being done to measure, monitor, track health outcomes of all kinds: birth defects, mortality, cancer, and asthma, and many other health outcomes. And the many environmental monitoring programs that were on to look at the quality of air, the quality of water, land pollution as measured by Superfund sites, brownfield sites, and so forth. And the commission said, and this was in about 2000, said, well, wait, the question is, how do people use these data? How do people at the local level in particular use these data to achieve change, if we've got people who are being exposed to hazardous waste, who are being exposed to unhealthy air, and we are looking at changes in health outcomes, how are we assembling those data and displaying them and visualizing them and presenting them and linking them in ways that local communities can use that information constructively to bring about change, to eliminate or reduce environmental exposures, to address significant health hazards, and to address issues of disparity. And while it may seem that we haven't learned anything in some cases, and we're still talking about these issues now in 2021 as though they were not changed since 2000, what the Pew Commission recommended and what the Environmental Public Health Tracking Project nationally has become is a way of assembling all of those data or many of those data and integrating them in a way that they're available to communities, to individuals, to non-governmental organizations, to policymakers. And it's important to understand that there has been and continues to be a real challenge between various constituencies that have attempted to use these data constructively. And part of that has to do with, and you'll see that as we talk about the data in a little bit more detail, the ongoing dialogue that's really been since the beginning of tracking, to understand whether or not this is a way of relating exposures to specific health outcomes, or in a more complex understand that we may not in all cases be able to say this exposure caused this disease in this individual, but looking at this entire group of people, they have clearly been inequitably exposed to this thing, and they also in many cases may have inequitable health outcomes. And while we can't always draw a straight line, understanding that complexity is part of what environmental public health tracking attempts to deal with. So how did we do that here in Maryland? So in the United States Centers for Disease Control and Prevention back in 2002 asked a number of states, including Maryland, to develop pilot projects to better understand how to use, display, and link health and environmental data. And so one of our early projects here in Maryland was to look at pesticide exposures differentially across the state and understand how to link those data together with health outcomes data, with other geographic data. These were some of our very early pilot projects. Maine, Wisconsin, California, other states also participated in this early work. Then from 2006 to 2008, Maryland, with the advent of the full tracking program, which was starting in about a dozen states, developed its first public and what were at that time thought to be secure data portals where people could go in and look at the portals and the data in more detail. And we used those data to for projects like, for example, looking at potential cancer clusters across the state in various locations with the aid of the Maryland Cancer Registry. Our first public portal was actually launched in 2008 with a variety of data. And what you'll see here in this slide is how we at that time allowed you through the portal to do this very sophisticated overlay with asthma as a health outcome, PM 2.5, that's particulate matter 2.5, an air quality indicator, and hazard, and poverty. And we, working with then our colleagues, Dr. Minxi Wang at the University of Maryland School of Public Health, developed this first version of the portal. And it allowed you to do a lot of things. It was very flexible. It allowed you to look at environmental hazards, social and demographic factors. It calculated rates dynamically so that you could look at adjoining areas, and you could do calculations of rates in adjoining areas, which is harder to do because you have to know both the population and the number of cases. It was a much more complicated program, and it was very flexible, and people used it a lot to look at what was happening in the state. But it did leave a lot of explanation and context to the viewer and the user. So it was not directive at all. It was not constrained. It was really an opportunity for people to just look and see what was there. But there really was a lot of context missing from that, which was built out in other parts of our programming, but not directly linked to the portal. So we've continued with that portal and that basic portal design, and actually it is, as I'll show you, the current portal that is on our Department of Health website. But we really, in starting our redesign effort 2 years ago, one of the things that we did was to do a gap analysis and survey from some of our more frequent users and the environmental justice communities and others involved in public health and the environment. And we got a lot of feedback from them, even during COVID, which is when the survey was conducted. But it had really, the way I would look at the data that we got back from that survey, there were two really fundamental concerns about the portal. The first was that it was acknowledged that it was really good to allow lots of exploration of the data. But what was really missing was context and understanding of what the data meant and how the data were linked to actual change and programs to bring about change. So with that in mind, we have really tried to fundamentally change our approach to the portal in this new version. And so you are going to be seeing actually our beta version of this, which is not yet released to the public. And I would stress at this point that the numbers that you're going to see are not necessarily actual numbers of actual disease rates and cases here in the state. Rather, they are synthetic data sets that we've constructed for the purpose of seeing how the portal behaves, testing it, and so forth. So I would just add that caveat to you. What we have tried to do in this is to rethink how we describe the data in a way that is much clearer, that is much more contextual, that allows the users to understand basically what are the data now, why are the data the way they are, and how do the data link to, and how do I as a user link to an actual program that is bringing about change or seeking to address this problem. So that's really our approach. And that's the overall design and structure of the portal. And for those of you who are used to looking at our previous portal, we'll be very interested to hear from you how you think this addresses the real needs of communities and individuals who are trying to make a difference with respect to environmental health. So this is a snapshot. I'll show you the live version, the live beta version in a bit, but this is a snapshot just to provide you with a little bit of an overview. So what you'll see is that the portal is still based on maps, and you can also generate data tables. And you'll see that we have tabs up here that help guide you from where we are now, the status of this problem or this issue, disparities, and by this disparities, we understand that this includes, in many cases, issues related to how we got here. Why are these data the way they are? And to what extent do they reflect deep and historical inequity and disparities, as well as, and I want to emphasize this, in some cases, either biological or physical or other kinds of drivers of differences that may be related to other factors as well. And then we have these two other areas. In this one, we've got more data, which is a way of generating additional data tables. And then a final tab that is not shown here is programs, which there are programs and interventions designed to fix and address the problem. And obviously a data legend here, and then text. And this is something that we have tried to do in brief to present both information about the hazard and also resources to address the hazard that may be useful for the viewer. We've taken a lot of care to try to provide context. And so we have rates, trends, and a way of selecting for data, both at the statewide level and eventually again in counties. And ultimately, in some cases, we will also show data at the census tract level so that people can understand their neighborhood or at least their community context, not just the county level data, which is one of the concerns that's always been expressed about environmental health data, is how to make it more relevant to individual communities. And as I noted before, we've got these a long list of resources that'll be useful for people who are coming to understand this particular public health problem. So the issue of health disparities is one we have tried to incorporate and tried very hard to use both the language and the sense of communities that have engaged on these issues in order to describe them. Working with the University of Maryland School of Public Health and Dr. Wilson and his team, we have attempted to use language that is sensitive to and reflective of the experience of people who have come to these problems or who are living these problems. We don't always succeed at that, and we will appreciate feedback when that doesn't work. As I mentioned before, you know, it's for some of us who historically grew up in a very science-based medical, clinical, public health realm. It doesn't always come easy. I will admit that frankly, but we have tried as much as possible to try to reflect where the communities are in terms of their understanding of these problems, their experience, and how they view attempts to look at the data. So, and we are always going to be constrained by the data themselves. So, for example, we have had long discussions about the issue of gender and race and ethnicity and how to reflect that in data, because the data mechanisms and surveillance systems that exist within the state and the federal government to describe race and ethnicity and gender, as you know, are limited. They have been expanding, but historically they did not always collect anything other than male and female. And in terms of race and ethnicity, frequently, historically, they were relatively constrained and you had to choose one box. And so only recently has there been changes that allow for people to reflect a more integrated experience. And in addition, as you know, we are also constrained by confidentiality that in many cases with groups that may not have as many members, have been identified or have been identified through historical surveillance purposes, confidentiality prevents us from identifying those individually, and instead compels us, if we're going to talk about large groups, to put them into broader categories. And again, we have to acknowledge that that is a limitation of the surveillance systems, but is one that is not, unfortunately, going to be solved in the short run. So the content that we're building into the portal will address health outcomes. It'll address health status as reflected by indicators such as life expectancy. It'll reflect environmental hazards and environmental quality, including climate change, a very important topic, obviously, now and into the future. Air quality, water quality, land quality, Superfund sites, and others. The built environment. And then we have social and demographic factors that are incorporated so that people can understand the background of the communities for whom they are whose data is reflected in the portal. And then, as I said, programs and interventions, as well as ultimately down the road, and this will not be initially, tools. And by tools, I mean things such as, I think we're very interested in producing tools such as tools to assess health impact. For those of you who are familiar with the idea of environmental impact statements or environmental impact assessments, EIAs, the idea of providing tools so that people can construct health impact assessments, HIAs, and use these data and the portal to engage with their colleagues, their communities, and others to say, what is the baseline health status of this community? What's the baseline environmental quality of this community? And down the road, how do we look at changes that are reflective of policy decisions that need to be made or that are being made to allow communities to better understand the context of how, without necessarily modeling those changes in detail, because that's a harder thing to do, at least they can understand sort of where they are now as a way of engaging with regulators, with community decision makers, to say, if you're going to make change here or propose change, you must understand the context of the community as it exists now, and provide people with more opportunity to engage in those important decisions. So with that, let me take you to the actual portal through the magic of something or other. And Joe, this is where I'm going to stop sharing my screen for a second and then switch to the other screen. All right, so
Perfect.
There's a new share. So let me stop sharing. And then let me reshare on the other screen. And that would be right. Oh, let me just do this quickly. And we'll see whether this works. All right, so now are you seeing my screen with the actual portal with the words asthma and childhood lead poisoning?
Yes.
All right, I'm terrified about this, but we'll see whether this works. So if I switch this screen for just a second to, oh, and I have to move this out of the way. Are you seeing now our environmental public health tracking home screen, or are you still on the asthma screen?
Nope, we're seeing the EPHT page.
So I thought I would start with just a little bit of where we are right now. And this is our landing page for environmental public health tracking. Thank you very much, Joe. This, as you can see, we have a whole series of topics here. This allows you to look at our county profiles, do mapping, and as you can see, where we are now is if you clicked on this, it would take you to our current map, which, although the data have not been updated, it represents our current map, and you can see that we allow you, for example, which we will also allow you in the new database to look at, I'll just create the map here. This is blood lead data. This is blood lead data by census tract. And as you can see, we can actually look at details by census tract to understand differences across the state and in communities. And you can see here is Baltimore, here is Prince George's County, Montgomery County, and you can see differences in rates. This allows you to look at different areas and bring up data in the individual areas. And this same kind of functionality will be incorporated in the new map, as I'll show you shortly, at the census tract level as well as at the county level. So that's just sort of where we are right now. Now, this is our beta version landing page for our 2 indicators that we've loaded currently into the beta version. This, as I noted, will be vastly expanded by additional health topics, environmental topics, other indicators, but this should give you an idea of how we start. So again, if we start with childhood lead poisoning, and again, I would emphasize these are not current data, they don't reflect reality, so just that caveat should be important. But when you come to the page, you'll see this overview of the problem, and already this is incorporating lessons from our feedback to provide more feedback on what is the actual context of the problem, and then a guide to the various, these are ways of navigating in addition to these navigational aids here. And then we have details about the data, why the data are important, data sources, the years of data available, and then detailed description of the data. Again, this is an effort so that people understand the context when they come to the site and can find out more information, and it also ways to contact us in order to take action. So if you go to, for example, status, as I indicated, this will allow you to look at childhood blood lead rates across the state. And one of the important things about this, again, for those of you who use tablets or mobile phones, is this is enabled so that it will display well on every device from a mobile phone to a tablet to a desktop system. And so in a desktop system, it will appear like this. In a phone, it will actually, this section on the right here actually will be down below, so you'll scroll. But as I can show you, this is our map that you come to when you start. It has, this is where we are right now. So this is the status of the problem of childhood lead poisoning in Maryland right now. It allows you to look at rates. It allows you to look at counts. And as it, and you'll see here, here's the legend, so you can easily see the legend. And it allows you also to look at data trends, which we'll do in a minute. One of the things that we've done is, as opposed to having separately generate the data tables, we've incorporated the tables right directly within the program itself. So if I hide the legend for a second, you'll see that immediately below is the data table. And so if you click on a particular county, it'll do 2 things. First of all, it'll show you details about blood lead in that county. And again, this will happen at the census tract level when we build in the census tract tab here. But it will also show you the county demographics. So this is a way of showing you the context of either the community or the county immediately. So we have here total population, percentage of male and female, the age and sex breakdowns by male and by gender. So you can actually see the age distributions. And then you can see the race and ethnicity composition here. And you can also see here other indicators such as median income, the percentage that have finished high school, and a link to more detail from the American Community Survey. One of the other things that you can then do is you can then look at a particular county. So here's the data table. And if I click on that county, you'll see in Anne Arundel, as we go up here, that it highlights Anne Arundel and it shows you where that is so that you can then link the data directly to the table. We also have over here our resources tab, and for our MDE colleagues, our Maryland Department of the Environment colleagues, where the Childhood Lead Poisoning Prevention Program is located in parallel with our program here in the Environmental Health Bureau, we've got a whole bunch of links that allow you, as well as to the CDC. So that's a sort of an overview of the navigation of the portal. Again, it's designed to work on any platform, and it allows you to understand, if you're out in the community, to get instantly access to data about that community. We're also going to be showing trends, and here you can see the trends in overall elevated blood lead levels and number of children tested. And so this shows you by year what's happening over time. And part of the reason for this is to understand where public health and social and community action is actually working. So this is showing you from 2010 to 2019, what's the trend in terms of the number of children tested, which is an intervention that we'll talk about more in the programs tab, and what is the impact of that in terms of health outcomes, as we see the number of children with elevated blood lead levels decrease by year. Again, while these are actually synthetic data, they do represent actually what is happening here in Maryland and the success of the efforts at every level to try to address lead poisoning, but note that we still have work to do. So that's where we are right now and where we've come from. How did we get here? So this is about what is it? And I know that Joe Galarraga has a session with us that we're also going to be talking about a little bit later to talk about Baltimore City and its lead experience. And I would commend that to you as a way of understanding the problem of lead here in Baltimore. But a lot of that is wrapped up with housing policies, redlining, and other policies that meant that communities with older housing, especially pre-1950 and pre-1979 housing, had tremendous problems with lead paint. And you can see that reflected here in the, and I can turn this on or off, you can see this as the housing that was built before 1980 by county, which is from the American Community Survey. And again, if you look at this, this shows you that in Montgomery County, the percentage of children under age 6 with blood lead levels is relatively low, and the percentage of housing built before 1980 is relatively low. If you look at Baltimore City, by contrast, we're still getting these data. So again, this is synthetic data. This is not yet publicly released. This number is higher for Baltimore City than in Montgomery County. And the percentage of housing built before 1980 is 87%. So those are the kinds of explanations of why the data are the way they are. One of the other things that we've done is we know that for childhood blood lead, education is an important issue. And as we zoom in, we have built in the provision to allow for people to see where community schools are. this is one of the areas where when we do this, you'll see the community schools show up. And this is a way of looking at important built environment factors that people use as touchstones in thinking about community environmental health, interventions, and children, a big focus as we move forward. So that's about disparities. Similarly, with respect to community poverty levels, again reflected by the American Community Survey, these are just some of the demographics that we have selected. And this is the children in poverty by county. And you'll see how these vary by county. Again, you can turn this layer on and off. And if you look down below, here is the data table, which shows you the actual values by jurisdiction. There's Howard County, and you can actually use that to illustrate and highlight the county there. So this just gives you a quick overview. The other thing that we have attempted to do consistently and intentionally is to drive you to the interventions. So we really want to understand not only what is the problem and what is the source of the problem, but what is the state, what are communities doing to fix the problem? So here we are looking at interventions that are specifically designed to identify children with lead exposures, abate those homes, and link them to our programs to abate those problems. So right here you can see testing trends. These are the percent of children under 6 who tested for lead, who should have been tested in each birth cohort. And you can see here, percentage is 30% in Allegheny County. In Carroll County, it's 26%. In Kent County, it's 22%. Again, these are synthetic data, but it gives you an idea of how we want to use these data to help communities identify how can we improve our community testing levels, which is a discussion between health departments, health providers, managed care organizations, and others to improve testing. Trends in testing shown here over time so that people understand whether it's getting better or worse, and it allows you to look not just at the state as a whole, but to look at counties in comparison to the state. And so this allows you to actually see whether your community, your county is doing better in terms of testing, not as well as, and it allows you to engage with public officials on, are we doing better? Are we getting better over time relative to how the state as a whole is doing? Is there opportunity for improvement? How do we do that? And we also obviously provide you with the means of looking at those data. And then aligned with these programs, you will see both resources and eventually with respect to, for example, lead and asthma, which are 2 programs where the state has committed significant funding over time, and even more recently for asthma, to our children's health insurance program, home visiting for children with lead poisoning or asthma, which operates out of local health departments in 9 jurisdictions, likely to be expanded in the near future as part of the state integrated health improvement strategy. And that strategy really depends on an intervention or series of interventions to address kids with moderate to severe asthma, a disease which does have significant disparities associated with it. If we go back to our landing page, as you'll see, if you look at disparities data for asthma, again, these are synthetic data, but they do reflect that actual experience here in Maryland and across the country. If you look at the difference between whites and blacks with respect to emergency department visits, this is actually the key measure that we are using in the statewide integrated health improvement strategy to look at rates between 2018 and 2026 to decrease those rates overall in Maryland for children age 2 to 17. Our goal is to reduce those by 42%, and for Black children, whose rates of asthma ED visits tend to be 4 to 5 times that of other children in the state. We have an even more ambitious goal of reducing that rate for Black children having to visit the emergency department on an average in a year. From 2018 to 2026, we want to reduce that rate by 50%, cut it in half. This portal is going to be the way we publicly track those data and measure our progress towards the statewide integrated health improvement strategy. And you can look at that both with respect to emergency departments and then hospital discharges. And then I haven't said a lot about the more data part, but this will be data tables that you can generate that are very long data tables with all the data from this particular measure. So it's a way of downloading and then using the data yourself, if you are so inclined, for more detailed measures. So that's in a nutshell, sort of a nutshell, where we're thinking of going. And at this point, I'd like to, Joe, I'm happy to stop sharing and pause for discussion or allow you to moderate the discussion or the chat. And I'll leave this up in case there are questions that come back to the portal, and I'll let you guide me in that.
All right, thank you so much, Cliff. Appreciate you going through, demonstrating the portal, some of the ideas behind the updates associated with the new portal. So there are certainly some questions in the chat. Also, I think if there's anything that anybody additionally wants to ask, now would be a good time to put it in the chat and I can read these out loud. This was a question from earlier on, and this is from Andy Fellows. I forget exactly at what point in the presentation this question came up, but it was prior to you demonstrating the portals. But is there a legal reason for listing possible cancer clusters rather than cancer clusters?
Thank you, Mayor Fellows. Yeah, there actually is a reason for doing that. And we've tried actually, there's actually at the national level, the CDC is revisiting the entire issue of cancer clusters and how we approach them. In part because historically there have been a huge number of inquiries to health departments at the state, local, and even the national level. In most of those cases, it's very, very difficult to say with any confidence that there's actually a cluster that is that can either be identified epidemiologically or for whom you can establish a link specifically between an environmental exposure and a coalition of clusters. One example of a cancer cluster that people don't necessarily think of as a cluster is mesothelioma, because mesothelioma is a cancer of the lung that's related to asbestos exposure, and it's related solely and exclusively in almost all cases to asbestos exposure. So there have been occupational clusters of mesothelioma, and then there have been environmental exposures, community exposures in places like Libby, Montana, which I'm sure you've heard of, where the exposures are huge and you've had entire communities poisoned by exposures. But in most cases, questions that come to the health departments about cancer clusters result in, at best, identifying concerns on the part of individuals or groups that can be addressed in terms of sometimes understanding whether there are inequitable exposures historically, environmentally, whether there is a possible grouping of cancers of similar types in space and time that you can then attribute to a single environmental exposure. Almost never happens. With the thousands, literally thousands of cancers that have been identified as potential clusters, all but a handful, we've not been able to say with confidence that there is really a cluster there that's related to unique exposure. It does not mean that there are not cancer clusters that are the result of exposures. Those have been shown in many communities across the country. But most of the inquiries that come to the health department don't rise to the level where we can say definitively, yes, there is an actual cluster of similar or related cancers that is related to some factor, whether it's an environmental factor or sometimes a genetic or familial factor. So I hope that's helpful. And it's never a satisfying discussion, but I'm happy to answer questions.
All right, thanks, Cliff. Hassani Domino in the chat asks, does this work nationwide, i.e. California? I'm going to answer that one. So tracking is a program administered through the CDC, and there is a California tracking program as well. So I just put the link to the chat for Tracking California, or I put a link for Tracking California in the chat for you, Hassani. It's trackingcalifornia.org. So hopefully you can find some resources there. They also have maps and data available there. So hopefully you can find things there that are useful to whatever your questions might be. Kim Lambert asks about deliverables to the community, plain language charts available. I guess I think that I'm maybe going to do a little of interpreting here, but Kim, feel free to jump in. But are there any plans to make some more resources regarding the portal and the data available to communities?
Yeah, and that's actually one of our very, very big goals is working with the University of Maryland School of Public Health and Dr. Wilson's team and to be Dr. Galarraga. Our goal actually is to do more community engagement with the portal and to use that engagement to further refine and develop products that are more useful for communities. We have historically made community profiles that are downloadable as Excel spreadsheet products. But I think our experience tells us that in many cases, what's useful to the community ends up being a discussion between the community and us as to how best to represent those. So I think we don't want to prescribe exactly what that community product is going to be until we have more engagement with the communities.
Thanks, Cliff. I want to piggyback on that as well and say that Dr. Wilson, myself, and a team of people at CEEJH are working to do outreach and technical assistance around environmental public health tracking. So please, Kim, if you want to reach out and you need any sort of specific materials, any thoughts that you might have, we're willing to conduct that technical assistance on a personal level. So I see you've followed up, and at the federal level, we are encouraged to communicate to the public at the 5th grade level. Yes, agreed. I think that we certainly need to make more materials that can communicate some of this at the lower reading level. So appreciate that comment. So Sabrina replies to the chat or poses another question. Can you explain exposures meaning and what kind of exposures will cause the cancer clusters of possible health issues, perhaps related to industrial land uses and industries?
That's an excellent question. And I spend a lot of my time working on that issue, both historically and with communities. Understanding exposures is one of the more complicated kinds of issues that we deal with. And I have to say, it causes, and my colleagues, and I will turn to some of you who are actually on this for additional comments about this, but it's a very challenging and complicated issue to try to deal with. And oftentimes what ends up happening is we use surrogate measures or proxies or substitutes because we can't actually know historically for any individual what is your lifetime exposure. Your lifetime exposure is the product of all of the places you've been, all of the things that you've done, the work that you've done, the workplaces you've been in, the places you've lived. And it reflects not just your current exposures, but also historic exposures. And that includes exposures that actually started before you were born. when you were in utero. And we know that there are persistent organic pollutants that can cross the placenta, and that if you measure cord blood of babies born, you can already see a certain percentage of pesticides and other environmental contaminants, which are lifetime exposures. So your cumulative exposure as an individual is an incredibly complicated piece to understand. And so if we're looking at a community and understanding how a community is exposed, clearly proximity to a landfill site with contaminated groundwater is potential exposure for people living there now and for people who have lived there in the past. But understanding for any individual whether or not they drank the groundwater, drank bottled water, whether or not that organic pollutant was present in the aerosols produced in the shower, we struggle with how to understand those exposures. And the best we can do oftentimes is looking at the people who are living there now and the relationship between the people who are living there now and the thing that you're concerned about, whether it's a smokestack or a landfill or something else. It's sometimes a very inadequate measure for exposure. It makes it very complicated to try to say, for diseases, how do we understand the relationship between exposure and disease? So those are some of the things from a technical point of view that complicate this issue. And oftentimes it's a very unsatisfactory conversation where the community ends up being frustrated because they ask questions that are really good questions, like, what about all the people who moved away from here? But we don't know what happened to them. And what about all the people who have just moved here, who are here now, but their exposure is reflective of their lifetime before they moved here? These are all the kinds of questions that really that make it so complicated to try to approach these problems and provide satisfactory answers.
Thank you, Cliff. Yeah, it's certainly, figuring out, disentangling all of different exposures that somebody might experience. It's difficult, and that's why we have tools like this, which can really just serve as a proxy to approximate things like that. So another question from Terry Green is, if there were shipyards in the area from World War II, can you measure legacy contaminants in the area on the public health of the community? So sort of a piggyback here.
Yeah, that's a really excellent question. And it's similar to the question that we just asked. The answer to that question is sometimes we can. It's often difficult to do with a tool like this, because this tool reflects our experience looking cross-sectionally at people who live here now and things that we're measuring now, and then people who lived in the past and people who were there in the past. It oftentimes, to do that, requires more specialized kinds of investigations by investigators, for example, at universities, researchers who will go back and contact people who used to live in that area, assemble a group of those people, and then attempt to measure their exposures and their health effects. But oftentimes, because our society is so mobile, it's very difficult to look at those kinds of legacy exposures. I will say, if you look at places like Dundalk and Essex and Highlandtown, for example, many people from the Beth shipyards and Bethlehem Steel lived in those communities. And as we look at that cohort becoming older and developing health problems, many of those health problems are almost certainly related to their exposures. But for an individual, it can be challenging to figure out what exactly that root cause was. But we do see that in those populations that used to work in those areas.
Thanks very much, Cliff. And thank you, Terry, for the question. Any other questions for Dr. Mitchell? Any other questions regarding environmental public health tracking, Maryland tracking in general? We have a little bit of time left.
I won't call on people, but I just want to acknowledge the many people in this audience whose names I recognize, who have done so much for environmental health and environmental justice here in Maryland and nationally. And I'm not going to embarrass them by calling them out by name, but I just really do want to appreciate all the work that you have done and are doing and are going to do to help advance the cause of environmental justice and environmental health.
Well, great. Thank you so much, Cliff. I think that we're going to maybe wrap up here. I do want to note that, as you stated earlier, there will be, right after this, in our second round of concurrent sessions for the day, another session on environmental public health tracking. We will be, Maryland tracking will be presenting alongside New York City tracking. And one of the things that Cliff was talking about during this session was how you could use the current tracking tool to better understand disparities and how various histories and legacies of policy have affected the current disparities that we see today. So we will be demonstrating that through a number of story maps and data stories alongside NYC. So if you're looking forward to that, you can join us. I believe that Paige, who is a CEEJH intern, has put the agenda in the chat, so you can find that here. So thank you so much. We will be doing that session, yes, at 1 p.m. after our lunch break. So thank you so much. Oh, one more question from Sabrina before we wrap up. Chemicals that are in the air but cannot be measured by equipment, what tools can be used to measure these, and can they cause health issues?
Oh, excellent question, Sabrina. And I will say, and I will acknowledge, both EJ Screen and the Maryland EJ Screen tool developed at the University of Maryland have used a synthetic measure, a measure that's actually compiled for what's called hazardous air pollutants, or HAPs, hazardous air pollutants. And it's basically a construct that looks at modeled air pollutants in the atmosphere, like benzene and other organic pollutants, and it attempts to create what's basically a kind of a summary score from all of those pollutants. And then it's modeled by area. It's a very complicated undertaking. The EPA does it, and other researchers use it. EJ Screen uses it. And it is a way, it doesn't directly tell you what health effects are going to happen, but it attempts to say, if you had this much of this series of organic pollutants, what would be the cumulative health impacts from all of the things we know that these chemicals do to people? So it's basically a risk score. And that's the way, at the moment, that's the best we can do to understand that.
Great. Okay. And another question from Veronica. Can the data be used to ID issues which can be addressed to ensure sustainable communities?
Actually, Veronica, it's nice to see you. Thank you for that question. Our climate change built environment indicators and tools that are going to be associated with that are intended for exactly that purpose. So depends, if you mean physical and environmental sustainability, that's obviously part of it. If you mean social sustainability and, for example, social capital, that's a little harder for us to get at, but we are very interested in trying to understand how to build this idea of long-term sustainability and how to improve it within the portal. It's an excellent question, an excellent suggestion, and I really appreciate it.
All right. Thank you all so much. If anybody has one last question, we probably have time for that.
If not, having lunch and more time for lunch is never going to be a problem.
Agreed. All right. Well, thank you so much. I think we can wrap it up here. Thank you, Dr. Mitchell. Thank for all the attendees. Thanks for everybody for their questions, their feedback. We very much appreciate it. Enjoy lunch, and we will see you as we continue through the last day of the symposium. Thank you.
Thank you.